Good evening, everybody, and welcome to this international webinar at Believers Church Medical College and Hospital. Today, it's a great privilege to learn from the doyens. It's a very special day. And we are going to learn about clinical decision making, which can be both shared and in a balanced manner. And for that, we have Professor Dr. Ed Pele, who is the Professor Emeritus in Medical Education at the University of Warwick, UK. A fellow of 3 Royal Medical Colleges, Ed Pele holds the President's Medal of the Academy of Medical Educators for Lifetime Achievement in Medical Education. In 2017, he was also awarded Honorary Fellowship, the Academy's highest honor. With leadership excellence of undergraduate and postgraduate clinical education at the universities of Oxford, Warwick, and Exeter. He has held visiting professorships in Ireland and Malaysia. He has taken strategic reviews of curriculum and research at several leading UK and international medical schools and universities. He was formerly the clinical lead for health and social care for children at the NHS West Midlands Strategic Health Authority. Since he retired from clinical practice, he has mentored senior clinicians and he chaired the Education Training and Professional Standards Committee for the Academy of Healthcare Scientists. He has also researched and published on value-based practice through the Collaborating Center at St. Catherine's College, Oxford. Most recently, he has been developing new degrees in digital healthcare science at the University of Warwick. He coined the term fusion sciences to describe the holistic preparation of scientists in the new specialism supporting individuals' health and well-being. A doyen in medical education and clinical sciences. It's a great privilege, a great honor to have you today for this webinar, Professor Dr. Pele. Welcome to this webinar.
Thank you very much.
And to moderate this session, we have none other than our Professor, Dr. Thomas Chacko, sir. Sir is the Dean of Medical Education at Believers Church Medical College and Hospital and is also the President of Director of Famer Regional Institute since 2007, which conducts a 2-year faculty leadership development fellowship program. He is a mentor and consultant in educational innovation, research and program evaluation, implementing competency-based medical education, quality improvement in medical education using WFME standards. He is the past president of Academy of Health Professions Educators and past secretary of General CRAM, which is the Southeast Asian Regional Association of Medical Educators. He's also the member of the expert committee of WHO at WFME to improve quality of medical education and public health internationally. Sir has done his international fellowship in medical education at Chicago and is one of the stalwarts and pioneers in medical education in India. So, sir, it's a great honor and privilege to have you moderate this session. Welcome to this program, and over to you for the moderation. Professor Dr. Thomas Chacko, sir.
Yeah, it's my pleasure to be invited as moderator and to have a distinguished person in the form of Professor Ed, who will be talking on this important session. Let me introduce the topic. Sorry. I wanted to share. Yeah. Are you able to see the screen?
No, sir.
coming, it's coming.
Is it possible now?
Yes, now we can see.
Yes, right.
Okay. This is a topic that is very important for clinicians and doctors. And I want to highlight the context in India that is making it even more important. And so we would all be looking forward to the presentation by Peel. Violence against doctors has become a commonplace, and you would have seen newspaper the highlighting the violence against doctors by patients and their relatives. Sometimes we professionals think to blame the patients. Are they only to be blamed for this? To me, these episodes or events are just symptoms of the problem. And we professionals need to look for the cause and remedy them. There are indeed cases that are reported in the media about medical errors, negligence on the part of doctor, and it gets sensationalized. And with commercialization of healthcare, there is also a reduction in the esteem with which the doctors are held by people in the society. The doctor-patient relationship is a relationship of trust, and that is built over a period of time. And Ed will be later in his presentation talking about personalization of healthcare and building the trust in various ways. Mostly, this violence against doctors has been capturing the imagination of the healthcare professionals. And one of the reasons is we are not communicating enough to the patients. And to think of the more core problem is the way in which we train our students, where the training and examination or student assessment doesn't assess the communication skills. And because of that, we are poor communicators. And we doctors focus more on the keeping with rapid advances. Yet patient satisfaction comes primarily from the sense of being heard and understood. And so we need to focus on that, and that is the problem. India is still in the stage where we are more paternalistic. We take the decisions for the patients without keeping the patient's interest or consulting them at all. Whereas in the Western countries, all this is part of their curriculum, and specific skills are imparted. And maybe one or two OSCE stations, they are there that test whether these things are addressed to in a systematic way. So patient-centered care is relatively new to us, and mostly the know-all doctor determines the treatment, the line of treatment. So we need to move from doctor-centered to patient-centered care, and by doing that, we can reduce the gap between expectation and delivery of care. So communicating with the patient effectively becomes critical. So as I was saying, We are still in the paternalistic stage where information and recommendations are given from our side, and informed decision making is done to some extent. It has started, but involving the patient in the shared decision making, and particularly keeping in mind values and preferences of what will work for the patient, needs to be gone into. And I am sure this today's talk will um, enlarge our horizon to see what are the possibilities and things that we need to proceed with and develop and include it in our armamentarium of skills in decision making, so that we engage ourselves in professional development. Tomorrow's doctors was long back addressed or introduced in the UK, and in similar lines, the Medical Council and the Commission in India also has identified the outcomes and attributes that the Indian medical doctors should develop, and um, it does include the need to be a good communicator with patients, with family, with colleagues, with community, and being a professional who is ethical, and all those things are there. But mostly it is on paper, and we need to translate that into actual practice. And finally, the real test will be when it gets tested and we certify these essential qualities in our examination system, and then declare the graduate as ready for practice. Fortunately for us at Believers Church Medical College and Hospital, we have a fantastic vision and mission statement which makes it explicit as to what we should be doing, exhibiting professionalism, excellence, compassion, and a holistic Christ-centered understanding of healing. And so we expect our medical graduate to be competent, caring, compassionate, and communicative. That's a very compelling message and direction. And we need to see that we are putting words into action. And we need to move forward by undergoing continuing professional development on these areas of needs. Because based on this, only through continuing professional development and reflective practice, all of us practitioners will not be able to improve the quality of care and become more patient-centered, and the patient satisfaction will need to be addressed as our core value. So under the continuing professional development, the gap between expected and what is there needs to be achieved, identified first, and we need to engage in institutional excellence and build capacity of our doctors so that we are in a position to respond to the concerns of the patients, and whatever gets picked up as faults in the system for its improvement, we need to be ready. And so there is need to build capacities, concerns of quality of patients. Patients and relatives need to be communicated effectively. They must be involved in decision making, and decisions need to be value based. And how we will achieve this, we will be listening to Ed to make his presentation. Over to Ed.
Professor Ed, sir, if you can please unmute your Mike?
Indeed. Thank you. I've got that.
Yeah, that's perfect.
I apologize. The connection dropped out for a minute or so, but I hope it's back there now. I'll just get on to sharing, and I will try to share. Now, can you see my first slide?
Yes, sir.
Good. Okay. So first of all, I'd like to say a very warm welcome to everybody and a big thank you to you for asking me to join you today, because it's a great privilege, and I hope that I can make it worth your while having come at the end of what I'm sure has been a hard-working day for you. We're only in the middle of the day where I am in UK, but I really want to build on the platform that Professor Thomas has given us. So what we're going to be doing is we're going to be looking at clinical decisions. We're going to be looking at personalized care, or personalized centered care, person-centered care as you've seen it. We're going to be looking at the way we collaborate with our patients in the decisions we make. And you've seen mention of values and evidence. I call these the partners in decision making, and we'll try to explain why. We're going to look at evidence in a bit more detail, and particular thinking a bit broader than the evidence-based medicine that we're all taught in. We're going to look at processes of reasoning, because the clinical encounter is all about reasoning. And then I'm going to be introducing aspects that you may not be familiar with, which is about shared frameworks of values, which is a key part of avoiding those sort of nasty confrontations that were mentioned in the introduction. So here goes. First of all, decisions. And I think the important thing when we're thinking about clinical decisions is that they often, the process of that decision making starts way before we think it does. It's like the iceberg with so much underneath the water. And clinical decision making is complex, it's often lengthy, and there are a number of different stages to it. Some of these are conscious and some are unconscious. As an example of what I mean by unconscious stages in the decision-making process, I'm referring to the sort of question that we sometimes ask ourselves: why has this patient come now? Why today? And there can be a lot underlying that. Decisions vary very much in their complexity. And the first thing that we often think about is what's at risk. Of course, life and death decisions are at one end of the spectrum, but there's a lot more to even apparently mild and commonplace decisions. They vary in terms of the amount of information that we need to make the decision. And we may have to pull in a lot of information. This is an interesting one, wanting to do the right thing. That a lot of the time, patients are thinking quite altruistically, and I hope we're thinking about the wider context as well. I know that your college is very much a Christian ethos-based training, and clearly your own values will lead you to be wanting to do the right thing. So may patients. It just may be a little bit more complex if we don't quite agree as to what the right thing is between the patient and clinician. But that's not a disaster, it's an opportunity. And finally, when we talk about shared decisions, I hope that in this non-paternalistic environment that we're moving into, that the vast majority of decisions are shared between clinician and patient, shared between teams. Occasionally, we need what I call shouldered decisions where the clinician needs to shoulder the burden. And an example of that would be in the middle of surgery when the patient is unconscious. The surgeon sometimes has to make a decision for which he alone or she alone is accountable and responsible. So come back to this why now, why today question, because it illustrates a little bit about patient values. Here's a lady, she's a 60-year-old woman worried about her headaches. So who does she talk to about her headaches? How does she decide how far to take them? Well, first of all, she talks to her daughter. Then she talks to a friend of the same age of hers who happens to know somebody else who's had a problem with headaches. And then she reads a newspaper article about the potential problems of missed headaches. And finally, she consults the doctor. What I'm saying is that the doctor and the consultation that we're concerned with is some way down the line. A lot's gone on before then. Think about another case, so that of a man. He comes to see you, and any of us who've worked in primary care will see this as familiar. He talks about the fact he's seeing blood in his urine, and you say, well, how long have you noticed it for? Well, I've had it on and off for a year. Why is he coming now? Why has he, what are the factors that lead him to make this decision to consult now? It's an interesting question, and one that we may find the answers quite revealing. Let's think a bit more about personalized care. This, to me, is the essential question of personalized care. What matters to you? All too often, we forget to ask it. We ask about the headache, we ask about the urine, we ask tens of questions about each of those. We go in great detail, but we forget the what matters question. And the what matters question is the most important question of the lot, because unless we understand how the patient lives their life and how we've no idea of how this headache or its management, or this blood in the urine and its management, we've no idea how that is going to fit in to this person. Personalized care is all about the individual. So we need, when we're thinking about the evidence we need to think about what the relevant evidence is. And it's not often it's not those huge, large-scale randomized controlled trials of hematuria or of headaches. It's got to be a much more relevant evidence. And we need to have the skills of finding relevant evidence. But it's also about something else. The what matters to you question is there because personalized care is about personalized values. And so personalized care depends on our understanding of the way in which the individuals, the patients, and their doctors or healthcare workers participate in this decision-making. Of course, that's a very complex issue, but I'm going to divide it into two. I'm going to talk about consensus, which means when we have consensus, it doesn't mean we're unanimous, but it means that we've reached a point where we both are broadly in agreement, or if it's a team, that we're all broadly in agreement. We can live with that finding. We've come to a point of agreement. And when we're talking about the evidence, That's where we're aiming. But there's another thing that's different. And I doubt you've ever come across this term because it's not a common one. But the other thing is dissensus. A healthy dissensus. Now, dissensus is the opposite of consensus. And I'm going to say a little bit more about it in a moment. But first of all, back to the evidence-based consensus. Why do we need it? Well, if we're talking about a team, if the team, whether it's the liver transplant team or the diabetes team, if the team has broad agreement on what best practice is, then that gives clients and patients confidence. If they don't broadly agree, then the patient gets all worried because this doctor doesn't agree with that doctor. So it allows much smoother team working. But we need consensus on the best evidence but in our consultation with the individual patient. Because if we can look at the evidence together and agree that's what the evidence seems to be saying, that can motivate the patient to make the changes that they need to make in their life. It can help with our goal setting as to what would be a good outcome of this consultation. So when we work towards consensus, let's look at it when it's the two individuals in the consulting room, the patient and the doctor. What do they need? They need to agree, first of all, what are we trying to do here? What's our goal? What do we need to agree on? They need commitment about, okay, do you agree we need to think about what the evidence is for the best treatment for diabetes in your case? We need that really valuable thing that Professor Tonchak introduced at the beginning, which is this trust and this openness. And we build that by being authentic together, and we need sufficient time. What do we need when we've got the team together? For groups, you need all of those, but you need a few other things. You need a clear process of how we're going to work on this. You need all members of the team to participate because you don't want anybody hanging back and saying, oh, you decide, I'm not part of this. You need good facilitation, someone who will see that the process is constructive, not destructive. And with that, you can get to consensus. And I would say it is usually possible to get a good level of consensus around evidence. However, for values, we're not really aiming for consensus. Not all the time anyway. Why not? Because we're all different. We all have different values. I have my values, you have your values. You don't have to change your values. I don't have to change my values. That's a key part of the understanding. We're not trying to convert one another to a different view. We're trying to understand, to appreciate, to respect, and to work with different values. So dissensus is more than just agreeing to disagree. It recognizes and respects this difference in our values. And what we aim to do is to find a solution that will balance things in the particular situation. So if we decide together we're going to follow this course of action, it may not totally be in line with my values. It may not totally be in line with your values, but it's sufficiently aligned to be okay for both of us. We can live with that. And another day, we might find we have to balance it in a different way. The key point about dissensus is there's no winner, no loser. Dissensus is a respectful process where we work together, where we have a different value. So take a situation, for example, where there is a religious value that the clinician holds and a religious value that the patient holds, and they're not quite the same. They have different religious values. What you're looking for is a situation, a way forward that does not involve the doctor having to compromise them, having to, I don't mean compromise their values, everybody's going to have to compromise, but not having to go against their own values, do something that would be absolutely wrong in their eyes, nor for the patient to have to do something absolutely wrong in their eyes. You're looking for this, this way of moving forward that is okay by both of them. So if you think about dissensus, just to convince you that we need dissensus, think about a time when somebody tried to change your values. I suspect that you really weren't very comfortable with that. You were probably even more uncomfortable if someone rubbished your values, if they trashed them and said those aren't values. You would, but then there's also the time when you really wanted to change someone else's values. And if you've ever experienced that this early in your careers, you might not have done that. But generally speaking, if you try to change someone else's values, it's not a very successful process because they feel the same as you would if someone was trying to change your values. It builds resistance and it doesn't get this working together, working forward. So we need this process that's not about changing someone else's values. It's about respecting and working with our own values. I realize that's quite complicated, but the more you think about it, the more it'll come to be meaningful to you. Let's think about how we do change our values, because our values aren't static. They usually change little by little. They don't change all at once. They always change from within us. Nobody else changes our values. We change them because we want to. If somebody attacks our values, they are so much a part of us that we usually defend them quite strongly. But the thing that can influence us most is hearing another person humbly explaining their own personal values, and that can be influential. So values change, but not because someone makes an attack on our values and says you've got to change those. Values change by example, by role modeling, etc. That's what changes values. Let's come back to the balanced decision making. And we talk about the 2 feet principle. Here you have a tightrope and someone is balancing on it using 2 feet. They need both feet because they'd topple over if they only had one. And the feet of decision making, the evidence foot and the values foot, are both of equal importance. And both of us, the clinician and the patient, both bring evidence and values to the consultation. So therefore, there are always 2 experts in the room, the patient and the practitioner. And this 2 feet principle of where values-based practice and evidence-based practice are the 2 components of clinical decision-making. I can't overemphasize it. It's very difficult to have balanced decision-making if you do not have both of those elements. So you, as doctors in training, need to think both about becoming really skillful in evidence-based practice and in values-based practice. Remember, as you're developing your skills in evidence-based practice, that it's not all about the doctor's scientific hierarchy here, where at the top of our hierarchy is systematic reviews. They are the gold standard evidence. It's also about individuals' personal evidence. And we all have our personal evidence, whether we're a patient or a doctor. I know because my dad told me. I know because I learnt it at school. I know because I saw a lot about it on Facebook, or I read it in the newspaper, or because I understand that to be a part of my religion. So we know all that is evidence. That's evidence. It may not be the formal scientific evidence, but it is evidence. It's what makes a patient believe that's right for their condition. And we ignore it at our peril. We have to work with it. So that's why you've had I suspect you've had a lot of teaching and learning around evidence-based practice, about looking out for the things that you really are a question for you, the things that are problematic, and turning it into a question, practicing your skills of finding appropriate literature, critically appraising it, trying it out, and evaluating it. I suspect you are well on your way to becoming expert in that. So do remember a few things. The first is that evidence is not proof. When you go into a court, you can only convict someone if the evidence is beyond reasonable doubt. Very little scientific evidence is beyond reasonable doubt. In my years in practice, much evidence has changed. The second point is, how relevant is this evidence? That was done on a large trial, but I've got an elderly patient in front of me, and when I really look into the details, there weren't patients, the inclusion criteria for patients in this trial were that they had to be under 60. So how relevant is that to my 80-year-old patient? Now I want to talk about when we do present our evidence. We've agreed with our patient we want some evidence about their condition. But you, as good doctors, have been trained in non-verbal communication as well as verbal communication. And you notice your patient fidgeting. Their eyes have become glassy and their focus is miles away. They're answering everything with the sort of, yes, but response. Or they're actually saying, doctor, I just don't believe what you're saying. So that is rejection. And we've got to be able to deal with evidence and resistance and rejection. Why does it happen? It happens because what we're saying doesn't fit with their values, or it's just not believable, or their personal experience is otherwise, or it's just too difficult. So personal experience, my dad lived to be 90 and he smoked all his life. Or too difficult is, well, I know I should lose weight, but I don't think the time's right. So when your skills show you that there's resistance here, I've got a lovely phrase for you, which I think it's helped me a lot, which is honor resistance. Don't regard resistance as all bad. It can be a gift. It helps us. If we notice resistance in our patient, explore it gently, sensitively, because you'll find out more about that patient values than almost any other time. You may need to park it and come back to it at another time, another consultation. But sure as anything, you will be able to engage in shared decision-making once you've recognized and not rejected their resistance. And I put this slide in because it just reminds me about being humble. If you think about all the COVID-19 policies around the world, every politician will say, we are guided by the science, but yet the policies can't all be right. I mean, the scientists, we have this phrase in England about they can't even agree the time of day. So remember, science is contested. It may It may help us, it may change. Just remember, be humble about scientific evidence. Yes, find the best available evidence, but remember that the best available evidence may change over time. And then finally on evidence, I want to just recommend a very interesting paper to you. If you think about, to take you through this slide, this is what's called single decision making, where the professional has to make the decision on their own. But this is dual decision making, where the professional uses evidence to help make the decision. This is triple decision making, where not only the evidence, but the patient preferences or values are involved in the decision making process. And what's exciting about this paper is that they introduce a fourth element into quadruple decision making, which is big data analytics, the modern data analytics, because what they've shown in Parkinson's disease in this case is that using big data, the clinician is able to be armed with much more precise evidence about what will help this patient under these circumstances. Exciting stuff. So go back, evidence-based medicine was founded in my lifetime, and the first book on it came out when I was in practice. And Dave Sackett and his friends talked about the best clinical decisions being made on the best available evidence, the experience of the individual clinician, and the values of the individual patient. So that trio is worth remembering. And I've been talking a lot, I'm going to give you 30 seconds, just write down what are values, because I've talked a lot about values, but we haven't really defined them at all. Just take these few seconds just to write, or if you haven't got paper, just think 3 words that mean values to you. Okay, well, here are lists that have been concocted from different workshops that we've done at different stages, because values are difficult to define, but they are something to do with all of these. And I hope that you'll find at least one of your words coincides with this. But there's an important part about values, however you define them, because values are action guiding. And here is a statement from the guiding document of our National Health Service, the principle of respect. I'll read it to you. The values of each individual, service user or client, and their communities must be the key determinant for all actions by professionals. So, if values are the key determinant, the key thing that we've got to think about, not the only thing, but we've got to bring them into account, then we've got to really understand quite a bit about values. So back to David Sackett, the father of evidence-based practice. By patient values, we mean the unique preferences, concerns, and expectations each patient brings to a clinical encounter, and which must be integrated into clinical decisions if they're to serve the patient. So that's hugely important. And that's what led my colleagues and I to sort of really get to work on values-based practice. We wanted a process that supported balanced decision-making on diverse values within frameworks of shared values. And I've been working at this now for at least the last 15 years. In 2012, together with my colleague Bill Fulford, we published a book about the essentials of values-based practice. And note here the round table, so that The round table is where clinician, manager, policymaker, patient, and carer all sit down because their values matter. They matter to each of them. And with the individual patient is the central point of values-based practice. It's understanding what matters to this patient now. You have it again, this what matters question. And that question requires me to become aware of the patient's values, but also it requires me to have awareness about my own values at play in this particular situation. We talk about values at play. It means the values that are relevant to this situation. And that is values awareness. And values awareness is the first clinical skill of values-based practice. Once you start from the fact that not everyone thinks like I do, you then move on to values communication, because you won't find out about other people's values unless you explore it sensitively. And building on what Professor Thomas was saying earlier on, hopefully you're not never going to get to the stage where you have bricks thrown through your window, but you may get to the stage of a complaint or even of a case against you. And the evidence in UK, and I can go into the evidence if need be, but the evidence is very strongly that when consultations go wrong, it is more often because clinicians were not able to deal with the values than because they did not know the evidence. They couldn't deal with the values. They weren't aware of the values. They couldn't communicate around the values. So something went wrong. And when that goes wrong, then you get patients in a conflict with their doctors. What goes wrong? Well, one of the big enemies of values-based practice is assumptions. And assumptions are important, as it says here, because the problem with assumptions is that they always come with blind spots. If we make an assumption, we don't know, we just guess. And I've got this big tip for you. This is a tip that I've shared with a number of people over time, but try it, and I think you'll find it works. If you hear someone using the word surely, surely you don't want to, surely we must, surely, whenever you hear the surely word, someone is making an assumption. Test it out and prove me wrong, but I don't think you will. Surely is a big assumption. Another point about values communication. I'm sure, and you'll tell me afterwards, but I'm sure that like, oh, wait a minute, I can't be sure. That's an assumption. I wonder if, like all UK medical students, you've been educated in your communication skills about exploring patients' ideas, concerns, and expectations. What sometimes is referred to as the ICE, and I don't like it being referred to as ICE. I like people to think about them in more detail. But if you have, then I want to add 3 more to your list of what might be helpful to explore. And that's the strengths, aspirations, and resources. Why do I like these? Because they're positives. They are positives. If you ask someone, look, it sounds as though life is pretty difficult for you at the moment. When you've been in previous situations like this, what's helped you most? You're getting them to focus on their strengths. When you ask them about, okay, let's check out where we're heading. What ideally would you like to happen over the next years? What would be your aspirations? And then when you look at the resources, the people who are there to help you, or the other things that you can draw on, you can get people thinking more positively and moving forward. And those I suggest to you are a great addition to the first three. I've not got time to go into this in detail, I'm afraid, but for those of you who are really interested in your developing your communication skills, I do recommend you look at motivational interviewing. It's highly effective when you're trying to get patients to explore changing their lifestyle. And the key things here are that you are not trying to convince the patient. You are using the skills of motivational interviewing to get the patient to look at their concerns and their intentions. What's good about this habit? What do you like about it? Or what actually are the downsides? What are the problems? Secondly, the successful motivational interviewing results in your patient, not you, arguing for the change and persuading themselves that they want to and can improve. They've got there because you let them get there. And just remember a few points. It's normal to be ambivalent about change, and it requires quite a lot of exploration of what motivates you and what your values are before you can decide on change. And above all else, motivational interviewing is a collaborative partnership of experts. It's the style that you adopt should be an empathic, supportive counseling style. You're just providing the conditions. You're letting change happen. Otherwise, if you try and use direct argument and confrontation, this increases their defensiveness and it actually reduces the likelihood of behavioral change. I think that's another key message, that if you want to reduce change, behavioral change, then you go hammer and tongs at your patients, arguing, but the evidence is this. You hit them with the evidence hammer and they won't change. You need to work with them. You need to let them explore it and get their own evidence into themselves that will convince them. Lovely, lovely paper by Miller and Rotnick that I thoroughly recommend to you. Very old, but nonetheless good. So we've been talking a bit about values-based practice. And like evidence-based practice, you remember those 5 steps of evidence-based practice? There are a few steps that you may find useful in values basing. The first is respecting diversity. Then, and without respecting diversity, you can't really have values-based practice. You need that mutual respect. You need to become aware of the values in play. We've talked about values awareness. You need the other clinical skills. We've talked values communication. There's 2 others I'll touch on briefly: values reasoning, values teamworking. And then we come to this difficult thing of the shared framework, and we'll touch on that. And that's what's going to result in the balanced decision making. So, values reasoning. There are 2 sorts of reasoning in values. I'm not talking here about clinical reasoning. Clinical reasoning, I'm sure you've done work on clinical reasoning where you look at pattern recognition or scheme induction, all the different ways of reasoning that clinicians adapt. If you haven't had a chance to explore it, look at some of the papers on clinical reasoning, and there's some really good resumes from those. But I'm talking about values reasoning, and there's 2 ways that people commonly do it. One is principles reasoning, and principles reasoning essentially, I won't go into this in detail, but it's the autonomy, beneficence, non-maleficence, and justice, which you've probably come across. I don't know, in UK, the the standard book on biomedical ethics is Beecham and Childress. But the interesting thing is that of those 4 principles, beneficence, maleficence, justice, and autonomy, Beecham and Childress themselves say the 4 principles cannot in themselves resolve individual ethical problems. So what's the point in having the principles there? The point in the principles is they give you a lovely framework to work with and understand a difficult ethical issue. They don't give you the answers, but they take you forward in an ethical way. And then there's case-based reasoning. The second way of values-based reasoning I find useful is case-based reasoning. It's looking at one case against another. What way is this case similar to or different from other cases I've seen? In that case, what did we decide? Does this change the way I think about this case? And case-based reasoning is the other part of values-based reasoning. I say a lot more about that in the handbook that you can have access to, which is called Pocket Values. But it's just remember that there are more than one way of reasoning. And the most important way of reasoning is the reasoning that your patient is comfortable with. Teamworking. Only got one thing to say about values-based teamworking, and that is that when you work with your team, whatever clinical team you're working with, whatever the skills makeup of that team, you're not just referring to them because they're the expert on this or the expert on that. You as a team are working together because you have different perspectives, different values. Use your team, let them contribute, and you'll come to a much richer, a much stronger decision, a much better balanced decision, by allowing everybody to say their piece and being respectful to all of them. So we're moving towards shared frameworks. And I've already said this is a complex idea and one that we won't be able to cover fully today. I just want to whet your appetite. But if you remember this, you challenge evidence and you explore values. So both the challenge and the exploration need to be done respectfully. And if you do that respectfully, if it's not just lip service, but if your patient can see in your eyes, you are authentically respectful of them in this, then you will go a long way and you'll probably get a balanced framework without me having told you how to do it. So the familiar argument, I'm sure most of us have had a variation of this. You know, I say left, you say right. How do you decide which way to go? Because straight on is into a tree. And basically, this is about the shared framework of values. It's not a matter of winning and losing. Neither of you, remember I said this right at the beginning, neither of you need change your values forever. It's not about that. It's about deciding an acceptable course of action for now. And if you're unsure whether to go left or right, why not do what the other one says and go left and see where it takes you? Because you'll at least have discovered it'll either be right or wrong, and then you can either turn around or not. But decide on an acceptable course of action for now. And next time we might find a different balance. We might take a better map or a sat-nav with us. So we've covered an awful lot of ground today. All it can be is a sort of introduction to shared decision-making, sharing with your patients, sharing with your colleagues, and to balancing it. There's an awful lot more to it, and I do hope you'll have fun exploring it. What I've managed to do is to get you free access to the book that I, with a couple of colleagues, wrote for my current students. It's an ebook which is constantly being revised, etc. And if you see any ways we can make it more helpful, do tell us, please. But that link will be sent to you, and you can use that link. You can also, if you just search Poshkit Values on YouTube, you'll find a few of the videos that we made using actors to demonstrate points about various different aspects of values-based practice. But those, I think they're very valuable, but I would use them with the book if you're interested enough to look at the book. And you can always email me on further questions if you want to. So with that, I'm going to draw to a close and bring you back to your moderator, Professor Thomas. Thank you.
That was brilliant, Professor. You have introduced us to a new world of shared decision makings with the pillars of values that are values and evidence-based. We were familiar with the evidence base and the need to practice based on what is the evidence. You rightly pointed out that evidence changes with developments in science. And what you also added was that patients come with their own baggage of what they consider as evidence. And then we need to balance and explore their worldview and arrive at a consensus. So these are all subtle skills and we need to develop, and for us to develop, we need to be aware of them. We have been told about the balancing in decision making and about the big data helping us to develop precision decisions, which are much beyond just collective consensus. And we also have value-based practice and recognizing that not necessary for us to change the values of our patients. They are to be respected, and we need to arrive at a consensus. There may be some point where we disagree, and it's beyond just agree to disagree kind of thing. And so Professor also told us about the value of motivational interview, where we use the patient in a counseling situation to address for themselves what are their concerns, what are the positive alternative ways, and you help them along to shared information and decision making. That was excellent, sir. You have given a lot of food for thought. This was just a preliminary exposition of the idea. I have seen your publication on this topic. I will share it with the audience. And you are kind enough to agree to share the slides as well, so that the audience can take off from the points that are mentioned there. And thanks for sharing your email ID also, so that those who have questions later on can get in touch with you. And also thanks for sharing the e-resource that you have been gracious enough to share. We'll wait for some questions from the audience, and we will see that they are written down in the chat box. Write them down, so that while Professor Ed is still here with us in virtual space, he can directly answer those questions. So we'll wait for some time. Over to Jacob.
Thank you, sir. That was indeed a brilliant talk. Professor Dr. Ed Pillay, sir. Thank you so much. We did get a refreshing perspective on clinical decision making, and I'm very sure that our participants will appreciate that. And looking forward to a few questions from our participants. We have one question from a student which has come through WhatsApp. Sir, in India, we see a lot of crowd mentality when it comes to OPDs. There's a lot of crowd, and sometimes we tend to get late with patients, and there is a lot of unrest. So I know that this is a little different from clinical decision making, but as part of a treatment spectrum, being in OPD, how do we handle this? How do we convince our patients, or how do we as doctors affect a culture change to prevent this or to reduce this?
That's a lovely question, and thank you. And this is not just a question of India, it's a question of where I come from and everything to do with it. I often get asked about time because to explore with a patient properly, to do a proper job of exploring their values when necessary, is very difficult. I think there are two parts to the question. One is that we do need to learn to get to the important, what matters issues with patients. And so I think that you will find you're still all relatively early in your careers, and you will find that communication skills speed up over time. That as you work, you do find that you can focus and take very, very careful shortcuts in your doing. My key to you is never miss out on the what matters question. If you don't know the family history, you might, that might be problematic in some situations. But if you don't know what matters to the patient, it's always problematic, because whatever condition you're dealing with in OPD, you're unlikely to make to get an answer that that the patient is comfortable with if you do not understand what really matters to them. So a minute, 2 minutes to understand that, how important exercise, or how important getting their personal relationships are, or their job is, or what, some idea of what matters to them is really important, and you never go wrong with that. So that's the first thing. The second thing is your skills as professionals. You will develop skills in advocacy in time, and just gently working with the people that manage the clinics to point out that not doing a what matters consultation actually is more time costly in time, because there's complaints, there's aggro, there's difficulties, etc. The more patient focused you are, the less time you have to spend, or the organization has to spend, on complaints. And they need to program the clinics properly, so that it may be that they're programming each appointment 1 minute too short. And if they put 1 more minute on a consultation, they will have a much happier and therefore healthier population. And it may be a question of the skills of deciding what you can do today and how you can bring the patient back tomorrow. All difficult skills, but I do suggest to you, I strongly believe it, that the bit that should not get excluded from a consultation is a question about what matters to that patient.
Thank you, sir. Thank you so much. I think that very well answers that question. Thomas Chacko, sir?
Yeah, my question to add is, can you give us some pointers as to how we can introduce sensitization of these issues in the graduate curriculum, as well as to those professionals who are already in service in the hospital?
Right. Well, I can tell you what we did at Oxford. We started with the surgeons, and my colleague Ashok Handa, we organized evening workshops for each group of surgery, for breast surgery, for vascular surgery, for every sort of surgery. And they gradually got a good reputation. They were very popular, and we got large numbers of surgeons there. And we included patients sometimes for these. And that was a big step forward, because up until those days, patients couldn't, it was not thought to be a very good idea to have learning with patients. But learning with patients we did. And I'll give you two examples of where this helps. One was that Ashok describes the way his practice has changed. Previously, a patient would say, he would give the evidence as a vascular surgeon. He would say, well, we could do this or we could do that. And the patient would say, oh, what would you do, doctor? And previously, he would give his opinion. He'd say, well, I think on balance, I would do this or I would do that. But now he never does. Now, when the patient asks him, what would you do, doctor? His response is, well, the problem is I don't understand enough about being you to advise you how to do it. Let's think about what it means to be you, what matters to you. And he will get much better results. This was adopted by the knee surgeons too, the orthopedic surgeons. There were some dreadful figures from Wales about the results of knee surgery. Only 75% of patients were satisfied with their surgery on their knees when they looked at them over a 2-year period. And only 5% of the problems were technical problems. 20% of the problems, 20% of the time, the operation had been fine, but the patient wasn't happy with the outcome because it didn't meet their results. So think of all the money that has been wasted on 1/5 of all knee operations because the surgeons hadn't had the skills to find out what mattered to the patient. The operation was a success, but the patient wanted to do things that they thought that knee surgery would do for them, and it couldn't. So that's another example. And it's, I've got other ones, but we'll come back to those if we've got time. But I would say that for graduate work, doing seminars, going through what it means to be values-based with a professional group and with patients there, particularly in the breast group, the patients were incredibly useful in terms of helping surgeons be more values-based and person-centered.
Yeah, based on your answer to that question, I get an idea. In our institution, as part of NABH, there is accreditation of the hospital. There are patient complaints, and the system asks us how do we respond to those. And we could have those complaints as the starting point to motivate our personnel to think about it, and they can be the problems that we can include in our workshop, and then we can work out uh, alternate ways of addressing it. And you rightly emphasize there is a gap in perception and expectation of the doctor, the care provider, and that of the patient. So unless the doctor and the care provider understands what are the expectations of the patient, it will remain as a successful operation, but the patient is not satisfied with the outcome. So
Absolutely right.
it's a very important thing, I think.
So we have a question from our student. He's in third year of medicine. So how do we communicate a diagnosis of an end-stage disease to a patient which you possibly suspect from examination? I think he's asking of your perspective in revealing diagnoses which are very, very bad.
Okay. Well, that's a lovely question. And end of life issues are a real time when values basing is so important. And the breaking bad news is a particular skill in it. So what I would say, some of what I say comes from the sort of general communication of breaking bad news, and there are a few principles of it. The first is time, that we should never break that bad news in a hurry. And it goes back to the first question where we were looking at OPD and the pressures on time of the clinician. And however we do it, we must engineer that time, whether it means saying to a colleague, I have to take time out with a patient now, or saying to the patient, look, I want to spend some time with you, and I'm going to finish at 2 o'clock, and I then will have the time that we need together. Or however you do it, you must have time, because you cannot successfully break bad news in a hurry. That's the first thing. The second principle is that you always try to do a little bit of preparation for it so that it isn't coming as a shock. And sometimes it's a question of, we need some time because I think there's some very important issues we need to discuss, or something like that. But it's basically, it may even be if we had bad news that we needed to think about, or serious aspects of this, who would you like to be with you? Would you like to get someone with you so we can talk about it together? Because it's always a good principle to have someone else there, because remember that when you tell patients bad news, they can't remember almost a single thing about what you've said. They'll ask questions, but they can remember very little because they were in shock after the bad news. So always try to ask, who would you like to have there if you can? So those are general principles. But then what about the values basing? The values basing, I would say, comes in earlier in the consultation, before you tell them about their terminal condition. You've understood a little bit more about their life. You've asked them what matters to you question in a way that you've got a good answer. You know who they live with. You know a little bit about their relationships. You know a little bit about their job. You may have covered, remember that slide about ICE star? You've discovered from the basic ICE, you've got their ideas about their condition. You've got their concerns, and you've got their expectations of what we're going to do today. But you've added to that something about learning about their strengths, about how they manage in times of difficulties, and about the resources who are there for them. So by doing the preparatory work before you do the bad news, it's all too tempting when you're not very experienced to bring the patient in. The patient comes through the door and you say, "I'm sorry, I've got bad news for you. It came back as cancer." Now that's not going to work. That's never going to work. It's basically, you don't know enough about this patient to make that work. So it's about preparing the ground and then using all the evidence-based techniques, because medical education is evidence-based like anything else, using the evidence-based techniques for breaking bad news. Does that help?
That's perfect, sir. Thank you so much. I think that perfectly answered the question. Yeah. So, yes, sir.
There's one more question. It says, if multiple doctors are involved in management, communication skill vary from doctor to doctor. So how to deal with that?
Absolutely. We're all different, and that includes doctors being different. And basically, that's where, if you think of the doctors as a team, particularly when they're handing over to different members of the team, that's where our teamworking communication skills have got to come in. And if you take, let's stick with end of life. So we've got the surgeon, we've got the oncologist, we've got the cancer nurse, and we may have a palliative care person in there as well as the somebody else. Over time, we cannot be a good team if we don't meet as a team. We must prioritize in our busy weeks somewhere, we must prioritize team meetings whereby we discuss, just as Prof. Thomas was saying about looking at complaints or where things have gone wrong. That's one thing we must do, but we must look at our practice. We must look at how we manage to make sure we are working compatibly together. So that team working, that building of respect, that agreement about the evidence. And if one clinician is saying that I always treat early breast cancer in this way, and someone else is saying, well, it should always be treated in that way, it's time for the team to look at the evidence and look at it carefully and to reach that precious consensus. And then there come the values. And the values, how do different doctors work with values? I think they do it in the way they communicate with each other and with the patient. If they're writing a letter to a colleague saying the thing that really matters to Mrs. So-and-so is this, the thing that we've discussed how we should move forward, and she is very nervous about chemotherapy because she doesn't want to lose her hair or something. How often do we put in our letters, in our communications, how often do we put those all-important details about what the patient is scared of, or what matters to the patient, or how we deal with the patient? And if we start doing it gradually, we can influence our colleagues to do it, and we can get this build up where it becomes a team. And very often one of the colleagues, perhaps a nurse involved in it, will act as a sort of helpful communicator between doctors on this. So we need to set as our aim that we're not just proud of our individual skills, we're proud of our team skills, and our team skills are patient-based, and we make sure they're patient-based because we talk about them.
Brilliant. So that was covered in your presentation about the team coming together, team perspective. The team brings their own expertise, their perspectives and values. And a discussion within the team will clarify what is needed for the patient so that we provide more patient-centered care and decision-making is done to avoid the confusion.
Yeah.
Thank you, sir. So if there are no more questions, so I think we can wrap this session up. Thomas, sir, is that okay?
Yeah.
Okay.
Speaker from UK.
Yeah, we are really grateful for that wonderful talk, Professor Ed Pillay, sir. We are extremely grateful so that since you spared your time and came over and gave this wonderful talk, and definitely our participants would be appreciating the insights and perspectives that you shared with us from a global platform. Extremely grateful for that. Thank you so much.
It's been a pleasure. Thank you.
And Thomas Chacko, sir, thank you so much for moderating this session. Your presence and your perspectives are always refreshing and always come as a wonderful addition to our sessions. And thank you so much for taking this time to moderate this session.
My pleasure.
And I also would like to thank all our participants from various states and countries who have come in to participate, and our medical students also who have taken off their time to listen to this very important aspect of clinical decision making. It will go a long way in training your brains towards this very crucial aspect of clinical medicine. So on that note, let us wrap this session up, and signing off from Believers Church Medical College and Hospital. On the 30th, we have an ophthalmology webinar, an international webinar. We have a doctor from NHS UK talking to us on ophthalmologic emergencies. So until then, stay safe, have fun, and take care.
You too.
Bye.
Bye now.